11:04, Dr. Payne Show. This is a call-in show, by the way. 416-870-6400, star 640 on cell. Back at her. How are you, pal?
Suffering.
What? Really? You got
a headache, yeah.
I hate headaches.
That's what we should talk about.
Are you like a migraine guy or no?
No, it's tension-based headaches, like muscular referral, things like that. Yeah, but it does tend to happen. I notice it a lot when weather fluctuates. I definitely get a few more, but yeah, they suck. I hate headaches. I don't get them that often. But
you're like me. I'm not a headache guy, but when I get them,
and people that have migraines, those are bad news. I mean, headaches are a tough thing. I mean, you get, number one, when you start having new headaches, you got to obviously eliminate the most serious causes of potential headaches, like brain tumors and things like that. A new stroke, if you're an older person, you have a new headache and you're older, you have high blood pressure, those things, stroke can be a symptom of stroke. So that's an important thing, obviously, to rule out.
You're scaring me.
Well, yeah, you're sort of old, aren't you?
Thanks, man. Jeez.
No, but I mean, it's important. And most of the time they're just simple mechanical headaches, right? But like everything, your job or our job or even your own job is to make sure that it's never something more serious, because it could potentially be life-threatening, especially something like a stroke, which is imminently life-threatening. So it's important to be aware of that. And so, I mean, again, if you're an older person, and now it's not just headache, it would likely be accompanied with some other things. I mean, most people, I think, would have seen the commercials around faces. So looking for, people's faces, if it's drooping, do they have motor control of their body? Are they slurring their speech? Are they coherent? All of those things paint a picture. And so it's very, very important. However, headache can be an initial sign following that, especially if there's something like trauma involved, then you're potentially thinking hemorrhaging. But again, most of the time, headaches are simply related to posture, the muscles. A lot of the muscles in the back attach at the base of the skull. And so as your posture changes because of sitting long periods, driving long periods, even being physical, whatever it may be, puts tension on those muscles. There's referral patterns, which are patterns that pain gets distributed in. And so you might have a problem, say, with the muscle in the back of your neck, but it could feel like the pain that you're feeling is, at the front eyebrow, for example.
That's weird.
Yeah. Even some muscles can actually cause ringing in the ears as a referral because of the pattern. So even weird things like that where people describe ringing in the ears, which could be a symptom of some type of muscular tension. But referral patterns are an incredibly crazy thing. Like, I mean, I guess the most well-known referral pattern is when you speak of a heart attack causing left arm pain and numbness.
Right. The left arm tingle.
Correct. And so that's an example of a referral pain, and obviously one that is obviously more concerning. But there's a lot of benign referral pain. So, you could have a back problem and you could feel it on the side of your leg near your knee, for example. You could feel it in the glute.
Tell me about it.
You could have pain in your upper back that radiates into the front, and it seems like organ pain. Like it might be like, I feel like the area of my liver or my gut hurts. So referral patterns are a very, very interesting thing. And a lot of the times those more serious issues, like when you're talking especially in the thorax area, if you're talking about potential heart attack or heart attack symptoms or cardiovascular symptoms or GI symptoms, once a lot of the serious things are ruled out, a lot of the times it's just simply muscular referral pain. And so that's good, because if you have that type of stuff, that's what you would want it to be, is muscular. Yeah. But you obviously don't want to start with assuming it's that and then potentially finding out it's something else. So it's always best to rule out the more serious cause of any type of pain and then work down towards the more benign causes that are treatable with conservative measures.
Yeah, it's funny when you mention, new headaches, and those who suffer headaches fairly regularly, migraine or otherwise, they kind of know it. I remember it must have been probably last winter. I woke up one morning, I was like, my left eye, it's like, I'm seeing spots. It's like I was half blind out of my left eye. And my wife goes, yeah, you're having a migraine. I go, but my head's not hurting. She goes, she goes, how long you've had the aura? I go, about 20 minutes. She goes, okay, 20, 30. She goes, about 30, 35 minutes, the other side of your head's going to be pounding. I'm like, get out of town. She was to the second.
Did you make sure it wasn't anything else?
Yeah, well, she knew. She goes, you're having a migraine. Yeah. And sure enough, bang. I'm like, okay, this side of my head's killing me. Now I have to go lie down. But I know, right? But she was, and she knows. She goes, you're having an aura you can't see over here.
Yeah,
she goes,
migraines with or without aura are important things.
Yeah.
And the aura types of symptoms are usually visual. And this guy never is even listening to us. Probably not.
Yeah, I think he is. That's Greg leaving his LR3.
So, what were we saying now that I'm
distracted?
Yes.
Nothing. We're going to a break anyway.
Okay.
Your phone calls, by the way, Colin shows you have pain concerns. Bring them on. At least start the conversation. 416-870-6400, star 640 on cell. Dr. Payne Show just getting ramped up here. Global News Radio 640 Toronto. 11:12. Yeah, time for you to call in. You got plenty as a call-in show with your concerns, be it pain or anything around that for yourself, maybe a loved one. 416-870-6400, star 640 on cell. And you can reach out as well, info@paincarecanada.com and 1-855-55-Dr. Lou, DRLOU. My mother-in-law, who's a sweet woman, nothing but the kindest of intentions, has been going to physio in your area. I'm not sure who she sees. You would probably know this person. And, just gets her physio done, comes home and goes back to the same sort of activities that are causing all her pain at 75 years old. So she says, hey, can I go see Dr. Lou? I said, hey, no, you can't. Here's why, dummy, because you're just going to go there. First of all, he's going to want to assess you. He's going to want to see your history. He's going to want to do all the things that you normally do and should do. Not her, you, I'm saying.
Yes, right, yeah.
And then after that, maybe he'll do some work on you, and it's going to be for naught because you're not going to do any home exercises. You're not going to take care of yourself.
Yeah, but I might be able to convince her.
Oh, this woman?
No?
No.
No, not this one, eh?
Sweet is sweet, but no. So I said, nope, you're not going. I'm not hooking you up.
There's a lot of people that you see. It's interesting. I've had a significant amount of people that when I tell them how important the active component is,
yes,
they'll be very honest. And I actually appreciate the honesty more than the lies. So I don't like when people say, yes, I'm going to do it, and then they don't do it. I think that's worse. I've actually had people that say to me, like, listen, I get it.
Dude.
It's not happening. Yeah. Not going to do it. I'm just being honest. Yep. What are my options? And now that doesn't mean you can't treat it and get better. You just have to mitigate mitigate what your expectations are out of it. So I think that's another important thing to consider is maybe that conversation where with someone like your mother-in-law, where you basically address the fact, like, here's the best thing that you should be doing, and this is the thing that's most likely to work. Right. In the event that you don't do that and you only want to do this, a lot of times for those types of people, it just means that they have to get consistent treatment. So whereas the intention with physical therapy should be, doing it for a period of weeks and then weaning off. Mm-hmm. If you're the type of person that you're not going to do your own home care, then maybe you're going to be stuck going there one time a week for the rest of your life just to have that maintenance care. And everyone has a personal choice. If that's your choice, if that's what you want to do, fine. But it's also about understanding, the risk of not doing
too,
exactly.
Right?
Yeah, and expectations are a big thing. And that's one of the things we go over with people. Like, what are your goals? What are your expectations? Because it's very important to set realistic expectations and goals. And it's actually more important when, and like I said, I actually appreciate meeting people that are honest about that they'll just say, listen, not happening. Like, no matter what. It's sort of funny. I had a younger guy that saw me this week. This reminded me of it. It's sort of a tangent, but 38 years old, family history of like severe osteoarthritis of the knee. Dad's needed knee replacement. He's well on his way to developing the same types of things. And so he was essentially, like, nothing big is going on. He just sort of wanted to know what are the things that I should be avoiding.
Right.
And so we were talking about avoiding things like excessive walking and blah, blah, blah. And so by the time we were done, he's like, so you're essentially telling me not to do anything. I was like, no. There's the right things you can do. I was like, what a bad doctor. Like, don't exercise, don't do any sports.
Do nothing.
Yeah.
Just Jabba the Hutt.
Yeah,
just
exactly.
Sit around.
Yeah. So, but there are, mitigating the expectation is very important. And even in situations like that, it's also about what are the realistic things that you can or cannot be doing. I think that's an important thing for people to digest. Not everybody has the ideal body type or based on injury, things like that, for you to be doing every single thing. Now, that doesn't mean you can't do it. It just might lead to the breakdown of your body sooner because, a good example is some people just shouldn't run, right? Because they don't have the mechanics for it. And so it's likely just going to create problems unless you really train yourself to do it properly, where, again, that's you need to make that effort.
And it's not that I didn't want her to come to you and get your help.
No, I get it.
I just know the type of person
thanks for your support there.
I just know the type of person she is. Forget it. Don't give him your money.
Do not see that guy.
Because I know the type of person she is, and it's going to be, you're not going to stick to it. She's not going to benefit from it, right? And she's going, oh, Dr. Lou, no, he's amazing. He would help, but you're not doing your part because I know your character.
Yes.
So continue to suffer, mother-in-law.
What a great guy you are.
Aren't I sweet?
What an amazing guy. It's bad for both me and your mother-in-law. Like, you know,
right, exactly.
Like, the only person that wins is you, so
Me.
you don't have to listen to either of us complain.
hear the
It's
crap
only
about
about
it.
you, eh?
I'm a great son-in-law, right? I'd like to help you, but I'm not going to.
Great co-host,
That's-
too. Love to send you a patient, but I'm not going to. Just sabotaging everybody.
Oh,
What a
man.
villain. You'd be a good villain, actually. Like, your look
be.
overall in a
What are
movie.
you trying to say?
You just doesn't he look more like a villain than a superhero? Like, definitely not a superhero.
Why?
Like,
Why am I not a superhero?
he's got the villain look,
You
right?
scare the little kids away. That bald head.
Okay, that's getting creepy now.
Like, you're not. Yeah, I wasn't talking
Yeah,
about
settle
little
down,
kids.
Jody.
Jody's. I'm picturing monsters. Jody's on kids.
I thought he'd be saving kids from monsters.
Yeah,
Oh,
there
come
you
on,
go.
Good point. Hey, well, this is a big tangent. This is a whole new area
This is
of,
a whole new
of
thing
the
of-
Dr. Payne show here.
We haven't gone down this one before.
This should be interesting.
Yeah, yeah.
Yeah. I don't even
seriously,
know where do you go from this?
I seriously
Speaking
might.
of monsters often have low back pain.
Do they really?
Maybe.
It's the position,
Yeah,
right?
yeah,
No, I
definitely.
seriously, I'm going to tell her to call you, but I'm just giving you fair warning that you're going to have your work cut out for you with my
John's not going
mother-in-law.
to be here after the break.
No, that's I'm done. 416-870-6400 star 640 on cell. It is a call-in show. Please save us. We'd love to talk to you here on the Dr. Payne Show. Global News Radio 640 Toronto. It is 11:21. Dr. Payne Show. 416-870-6400 star 640 on your cell. You have pain concerns. Want to talk about it?
Monster concerns, whatever. Yeah.
Whatever. Monster concerns. Any concerns.
Anyhow,
Oh, man.
where are we going?
That's up to you.
Well, so as always, the knee clinic, right, is it's been an incredible success. I would say we're really helping a lot of people with knee injuries. In terms of whether they're acute or chronic. And so, you know, with the acute injuries, what we're really trying to do is identify those people that need early surgery so that we can get them in very quickly and they can get surgery and they can recover quicker.
That are beyond PRP, the ones that are no
Yeah,
good
so
for
PRP is more for the chronic issues,
Okay.
right? And so there's two different things when we're assessing. Like, number one, someone who sustains, like, what's a good example? You're playing soccer this weekend, like indoor soccer, obviously, and you twist your knee and
Yep.
you feel
And you go
something,
down.
knee
Yeah.
swells. You know, in the traditional model, it might take you months to figure out that there's a torn ACL or meniscus. By the time you get that surgery, months could have passed. The research is pretty clear. The sooner that you intervene in these types of things, the much better your outcomes are. So this clinic is really designed to identify people that need surgery and get them in right away. And over the weeks and months that we've been doing this, I've talked about examples where we've had people, you know, from day of injury to a week later already having surgery. That's incredible.
Yeah.
And the outcomes of these people, it's incredible. And you know, we're actually doing it for some other types of injuries. So shoulder injuries, give me a call if it's potentially surgical. But then obviously we deal with the things that are subacute and chronic as well. We don't just deal with acute injuries. And one of the big things around the knee is, as a chronic injury, is osteoarthritis, arthritis of the knee that eventually needs knee replacement. And so, you know, the PRP injection we find it's really good for that person who has the swelling, has the knee pain, but still wants to delay the eventual knee replacement. This is not a solution in terms of it's going to reverse the arthritis, it's going to change anything. No, it's going to eliminate the inflammation, which helps to control your pain, which means you can go longer before you have to have a knee replacement. Because as we've gone through in previous shows, the stats are pretty clear that within 15 years, about 85% of knees that are replaced need to be replaced again. You would like to ideally try to do it one time in your life.
Gotcha.
Right? So that means delaying it until about 70 to 75 is probably a good idea. What if you're someone who's 55 and you've got a lot of knee pain, you've got swelling, you've got arthritis
Might
going
be two
on?
more times potentially, right?
Yeah, exactly. So it might be a good option to do other things. And so PRP is not the only thing that's a solution for this. We actually try to do a combination approach where we might use PRP along with specific therapies and other modalities to get these people. Again, we're not curing the issue. We're just helping them manage it to the point where we can delay what would be an eventual knee replacement into an age that would diminish the likelihood that they would need it a second time in their life. But we're not just dealing with osteoarthritis of the knee as a chronic injury. Some people have chronic meniscal tears. Some people have just chronic knee pain due to muscles that aren't working properly. There's lots of things that we address in the way we go about it. And so the knee clinic has been overall, I would say, a very, very good success, mainly for what patients are getting out of it. And so, the patients I've seen people all the way at the end stage of osteoarthritis, to people who need early surgery, to people, like I was mentioning, this individual who just is looking for, what's my advice on what should I be doing? Another big thing is people who can realize, hey, there's a family history of a problem, and I already have some of the early symptoms. If you're in that 20 to 30 age range, and you'd like to be doing things now to potentially help control those things, there are things that you could be doing, and that's called prevention. And a lot of those things are just meeting with me and going through the self-care, like what are the things you should be doing on your own, what are the things you should be avoiding, and if you do those things, that will help to delay the onset of these things, and really minimize its impact on your life, and that's an important thing. And so taking into account your family history and the early signs and symptoms that you have with something like knee pain is extremely important. Then obviously we deal with any part of the body. In the last few weeks, we've dealt a lot with the spinal stenosis issues. And again, this is another area where it's not necessarily looking for a cure, but how do you manage this issue? Right. How do you get these people who are the elderly population who have degenerative stenosis, who have difficulty even walking to something like 50 steps? How do you get them to a point where they can at least walk and go to the grocery store, for example, and walk around in a grocery store? We're not aiming here to get someone running a marathon. Right. It's just so that you can continue with your life, with your activities of daily living, and that's very important, because keeping that autonomy is important for the elderly too, right? Because it gives them purpose, it gives them a reason, and there's less likelihood of mortality when people have a purpose and can continue doing the things that they want to do. So in a way, it's a very, very important program that we're helping people with. But those are some of the newer things that we've really tried to I won't say specialized, but definitely focus in on. But then again, we're seeing everything: the shoulder pains, elbow. You were saying your elbow pain, wrist issues, ankle issues, hip issues, obviously spine-related issues. We're about to see a surge for sure in low back.
Is that because of an aging population?
I meant seasonally. I always find right around this time of the year, and then we'll get probably a snowfall.
The snow shovelers?
Yeah, somewhere in the next few weeks, and that shoveling that snow. And not everyone that shovels snow is rupturing a disc, for example. A lot of times it's just muscular soreness, and so we tend to see a spectrum of people that present with varying types of low back pain following shoveling snow, all the way from simple muscular strains all the way to people rupturing a disc in their back and creating like some really big problems. So it's really important that those things be addressed right away. Obviously, the most important thing is preventing it. So shoveling the right way, having the right type of shovel, understanding the mechanics behind it is very important. But it's not always possible to prevent those things. And when they do happen, the next most important thing besides prevention is early intervention. Yeah. Right? So if you're feeling something, intervening early is your best option always. Waiting is never, never, never helpful.
Done a lot of extensive work, of course. Dr. Bragava and Dr. Gordon have been on the show several times, lots of times for the knee clinic. Do you find even now, say compared to 15 years ago, that if it gets to the point where you're looking at knee replacement, that surgery and the techniques have gotten a lot better? You're coming out of it a lot sooner, possibly, and the rehab.
I think so.
Yeah, probably.
Yeah,
right?
I think stuff is always advancing. That it's not just the surgery itself as much as it is a lot of the protocol around these things. So even the rehabilitation or prehabilitation programs have gotten better. A lot of surgeons are now recommending that someone does, like, I had a patient, was it this week or last week? It was actually interesting. Knee replacement. Sorry, not a knee replacement. It was a repair of an injury, of a meniscus. And she had asked the surgeon, should I be doing therapy prior to the surgery? Yeah. The answer was no, not necessary. Okay, she didn't do that. Then even following the surgery, should I be doing any therapy? No, you could do a lot of it on your own just at home. She's in horrible pain right now.
Wow, no kidding.
Yeah, it just not has, and I couldn't even believe that was a protocol that anybody would follow anymore. Like, a lot of the people that work with me are very much about, no, you need to do this first. then we'll do a surgery, and then you need to be doing this. And it's when you look at surgery, you're not looking at a static moment like
the day of.
The day of surgery it's a planned procedure. Like what are you doing 6 weeks leading up and 6 weeks following, and then even broader, 6 months before, 6 months after. Now it changes based on the timeline, but definitely being prepared and then doing the right things after, so crucial, crucial. Yeah.
Talk about more about that and your phone calls. We have time and space. 416-870-6400 star 640 on cell. Want to reach out through email as well. info@paincarecanada.com. It's the Dr. Payne Show. Global News Radio 640 Toronto. 11:32 Dr. Payne Show. Plenty of time for you to call in. You have questions, concerns, just want to ask a question. 416-870-6400 star 640 on your cell. So details. How does it work? Calling the clinic. Assessments. All that stuff. Because you got to remind people.
Sound like Dwight Schrute. Question. The free consultation is a call or an email. Send me an email or a phone call with your name, your contact, a very quick description of what your problem is, and then I will contact you. I prefer to do the free consultation over the phone, going back and forth through email. Like what we can achieve in 100 emails, we could probably achieve in a 30-second phone call. And then that's really just to sort of start to identify what does this seem like, and am I or my team the right people to be helping you with this or potentially helping you with this or not? And once we've determined if the issue is no, we're likely not the right people or I'm not the right person, I'll make the recommendation on who I believe the right person should be. If it ends up being me or my team, then it usually starts with an assessment. Most people that call would like to see me the first time for the assessment, and I'm happy to do that. And, in the assessment, we go through a detailed history of the problem itself as well as your other relevant medical history. So everything all the way from family medical history to your personal medical history to what your life is like. Like all of these things matter, although some people think, well, why does that matter? It does. Like what your life is like very much matters when you're considering pain management. And then we'll go into a physical exam. Physical exam includes things like assessing the motion of the area and other areas surrounding that area. Neurological testing, always making sure that there's no problems with the nerves or indications that there might be something more serious going on in the brain or the spinal cord. Moving into specialized orthopedic tests, if required. Palpation, so just feeling the area, seeing what's going on. And then after that, we make a determination on is more information required through imaging, testing, whatever that may be. If it's not, then even if it is, we still will always move on to the diagnosis, which is a diagnosis isn't just, okay, here it is. It's often, here it is, but it could also be this or this, right? Because a lot of things could present the same way. And when you're dealing with musculoskeletal injuries and pain management, it's not like, broken bone is easy. You take an x-ray, it's like, that's broken. There's no ifs, ands, or buts. When you're dealing with people's pain experiences, it can always very much change. And then we come up with a prognosis, so how likely you are to recover from whatever it is you're dealing with. And followed with a plan of management. So how do you manage this now? Like, what is the game plan here? Are you doing therapy for this? Are you doing self-care for this? Are you potentially being referred to a surgeon to deal with this? Are you being referred to some other type of specialist for other things like injections? And that's the game plan. Now, I always involve the person in these decisions because I may think... Not I may only think, but also the research may support that a certain intervention is the best possible thing to be doing at that time. But what if the patient doesn't want to do that? Like, what if it's like, this likely responds best to surgery. The patient says, no, don't want to do surgery. Not like, I don't just let them walk out and say, okay, well, sorry, that's like your only option. It's like, well, no, here you go. Here's something else that you could be doing. Here are a couple of other things. It's just, again, going back to how we started the show, in the event that those things happen, all I really try to get across is mitigating their expectations at that point. Your mother-in-law is the perfect example. Like, if the answer is self-care and she says, no, I don't want to do it, it's like, fine. There are other things, but here's what you can expect when you do those other things. Maybe it's continual therapy for a long period of time. Maybe it's likely not full or significant recovery. And I just like to make all of those things clear. Now, the other thing that's always very, very hard is no two people are exactly the same, right? So I can recommend something for someone and think that they're not going to do well with it in terms of if they're not willing to do the best approach, and then they do that, and they all of a sudden, do really well with it. It's just that's the way it is. And some things that you think will help people sometimes don't. And that's where communication between the patient and the practitioner is also important. So I always encourage the patients, once I've referred them to another professional in the team, is make sure you're giving the honest feedback to the practitioner you're working with. Don't just tell people, yes, I feel better, because you don't want to insult them or you're afraid of hurting their feelings. And I understand that, but they're professionals and they understand.
They can take it.
They can take it. For them, it's more about, it's the communication. If you come back in and say, actually, no, you know what? That massage didn't work. I'm not feeling better. That's an important thing to understand, because the other thing that happens is when you just say, yes, that helped and it feels better, they'll usually continue down the same path. Right? And then you get to a point where, as patient, you become frustrated. You're like, this isn't working. You stop, and then you don't get better. And a lot of people that I see, I hear that very often, where someone will say, yeah, I started doing therapy. My doctor had recommended therapy. I went 3 or 4 times, wasn't helping, so I never did anything again. It's like, not all therapy is the same therapy, right? So you can't just say, oh, I tried therapy and it didn't work. Well, what does therapy mean? Did you try the right type of therapy and it didn't work? And I've never found the answer personally, like once I investigate, to be, yes, I've done everything and it hasn't worked. And if you're doing the right stuff, it usually works.
That assessment, by the way, 1-855-55 Lou, DRLOU. You want to reach out when we're not doing the show here. How long does that assessment take?
It's hard to say depending on the injury. Sometimes they could be as quick as half an hour because it's a simple problem. And sometimes it could be as much as an hour and a half, 2 hours.
Wow, that's pretty in depth, eh?
Yeah, and so it just really depends on. I try not to rush people. Now, what I will do is when I'm speaking with someone in the free consultation, I'm also able to identify, is this simpler or more problematic, and I will have my team book accordingly. So if I think someone's going to take 2 hours potentially, then I'll say, slot that for 2 hours because I don't want to have 15 people waiting for me in the waiting room. So it's done accordingly in that sense, but it's very hard to say depending, like as a general rule, what an assessment could be. It does, again, very much depend on what the issue is. But I would say, and the half an hours are extremely rare, I would say probably a good average is like 45 minutes.
And you always believe, always in the physical. You've got to be there. You've got to get in there. And if not manipulate, get some sort of physical.
I had someone send me an email yesterday or the day before, and it was pretty much for her father. 2 sets of x-rays, I believe a few years apart, both show severe osteoarthritis of the knee. She described her dad's symptoms as really bad knee pain, lots of swelling, all of those things.
Right.
When you just base it on what you've heard like that, it sounds like, probably going to need a knee replacement. Okay. But I can't make that recommendation if I don't actually see somebody in my office, move that knee around, speak to them a little bit more. Like, it could vary. Like, my advice might be the exact same. I might see that person and know within 2 seconds, but it matters to actually visibly look at the body part, to move it around, to do things matters so much. Like, we often talk about that we can diagnose this through our hands. Like, we can take somebody's joint or limb, move it around, and start to understand a lot of information. Right. Yeah.
Short break. Calls. Feel free. It is open. The lines. Call in show till just before 12 o'clock. 416-870-6400, star 640. On your cell, Dr. Payne Show continues. Global News Radio 640 Toronto. It is 11:43, Dr. Payne Show, right here. I'm trying to get a hold of my sister-in-law, who's normally on her phone 24/7, social, texting, blah, blah, blah.
Not when she sees your number, buddy. She's like, done.
That's what
everybody has somebody in their life that it's like, I'm just going to pretend I did not see this one.
Oh, sorry.
I feel like you would be that guy for a lot of people.
My battery died. I didn't see your message. No, but my sister-in-law, as you know, she's like a model patient, which is surprising because usually she's not the model anything because she just, she's a she's a slacker.
You're just a great guy. Dude, towards her. She's not model at anything.
She loves me.
Oh my God.
I'm razzing her because she's probably listening and she hasn't called in the show. So she came to see you.
She did.
And she did her homework.
You referred her to me.
Yes.
That was so you're 500. You're batting 500 on family referrals.
That's right. But tell the story. She did the homework, and she's been
She
doing
did the homework.
right?
Like, I mean, you know the story better because you've seen her in practice with the outcomes. She hurt her back. It must have been the summer, right? Like, at this point, it was a while ago.
Yep.
And initially, she went in. She saw somebody in the team, like, for therapy. She was recommended to be doing, like, the home care and that type of stuff. And she wasn't really doing it, in all honesty. And then I guess it got to the point where she started getting really frustrated, too, with what's going on. And she came to see me, and I sat her down, which is the same thing I would have done with your mother-in-law.
Right.
And I gave her the honest opinion. And same thing, I just had the honest conversation with her. Like, I talked to her about what I've seen in the thousands of patients I've treated, what I've seen in the research. If you don't do the self-care, if you don't do these things that I'm suggesting you do, you're going to be the way you are. And it's likely going to get worse. And don't be surprised.
Yep.
Do not be surprised. Well, the other thing was there was a component of like thinking, could this be something even more sinister? Could this be worse than just simple mechanical pain? People, 99.9% of low back pain is mechanical in nature. It's just the way it is. There's the rare stuff is rare for a reason. And so it's good to make sure it's not that stuff. But a trained practitioner can very much tell when there's cause for concern. Like when I see a patient, just based on questioning, I can tell when there's quote unquote red flags, when there's something like, we need to investigate this further. And so it's I'm not saying it's easy for us, but that's what we're trained for.
Right.
But she is the model patient in the sense that she took that advice, said, you know what, I need to be doing this for myself. If you're not going to do it for yourself, then who's going to do it for you? She went home, she started doing that stuff for herself, and like you've said, she is doing much, much better.
What a difference!
And the reality of, and I very much made her understand, you now have this issue. You have to keep doing this stuff. That's the other thing about this stuff. This is not like, I'll do this for 3 weeks and then I'll stop. Because guess what? If you stop, the problem will come back. It's like if you with losing and gaining weight, if you have needed to exercise and eat healthy to lose weight,
why
and
stop?
then you stop, are you surprised if you gain weight back?
Right.
No, that's just the reality of what happens. Some people will just naturally gain weight back, and it is what it is. And the people who naturally don't need to do anything so that they don't have back pain probably don't have back pain.
That's right.
Right? Simple.
And I every so often when I see her, once a week or every couple of weeks, I'll say, "So, Cammie, you how's the back?" She goes, "It's so much better." Are you still do it? Yep, every night.
Good.
Religiously. Does her work.
Perfect.
Does the homework.
And how many
it's
times
paying
does she
off.
have to see me for that? One time.
One time. That's right.
One time. And that's and a lot of people have actually followed up with me throughout the years of this and been like, I saw Dr. Lou one time. That's it. One time. I saw him one time. He told me what to do on my own. Never had. This is not like there's a $5,000 package behind every single the vast majority of people are like, here, go do maybe some low level intervention, or if they get put into the OHIP system with us, then it's covered by OHIP, or the one fee that happens with the assessment is my assessment fee, because all I'm doing is new patient assessments and I'm trying to get everybody done, so it's a $75 fee. That's sometimes people are like, that's it, like $75. That's it. $75 is what it'll cost you to have an assessment with me. That's it. And that might be the best $75 you spend. Like, I've met people that have spent thousands and thousands of dollars on certain injuries without any improvement whatsoever. They see me one time, get the extent of the conversation that we have to have. Sometimes I'll recommend that someone follow up with me in 6 months. Another $75 6 months later. Like that's what you're looking at for maybe $150 a year.
Yeah, it's she's got an okay pain tolerance, but and when she first started doing the exercises, they were tough. Yeah, they were painful.
100%.
But she stuck to it.
Yeah,
she stuck to it. I'm proud of her.
Yeah.
She's done really well.
And it's been. I'm trying to think. I probably saw her back in September.
Yeah,
is that about right?
Around there. Around there.
So she might be getting to the point too where she might be due to see me again just for progression of exercise. Because the other thing is adaptation.
Okay. Gotcha.
Which is an important thing. So if she finds where it's like, hey, all of a sudden, I feel like I'm stagnant. Mm-hmm. Stagnant, don't wait for...
plateaued, basically?
Yeah.
Like working out, right?
Yeah, exactly. If you're doing rehabilitation, you find plateau, don't wait for plateau to turn into regression. At plateau, do something to continue the improvement.
Yeah.
Yeah.
$75 to see you once, I would have paid that 2 years ago. I never had to see you again. Maybe $75,000, eh, Jody? There, I got you back. Crazy bastard. 416-870-6400 star 640 on cell. Still have time. Call in, ask questions. That's why he is here. The Dr. Payne Show on Global News Radio 640 Toronto. It is 11:52. Yeah, still got some time. 416-870-6400 star 640 on your cell. Hugh, hello there. Good morning.
Good morning.
Good. What's going on, pal?
Well, I have a hereditary disease that I've had for about 10 years. My sister has the same problem. She's 10 years younger than I have. And my son has been diagnosed with the same thing. He's 55 years old. I'm 83. It affects CMT affects the legs, and I have a difficult time walking and things along those lines.
Okay.
And I'm just wondering whether the doctor has any insight in regard to that situation.
Well, what has been recommended for intervention for you now?
There hasn't been any. CMT is a unknown sort of medical situation that doesn't have any research. Apparently, it doesn't have any insight in regard to anybody that I've talked to my doctor and I've talked to a couple of other doctors, and it doesn't seem to have any effect on what my problem is.
Yeah, right. I mean, it's a pain syndrome, so I mean, a lot of the times the treatment is going to be very similar to the way that it would be for a lot of other things, where it's multimodal intervention, where there's a combination of medications,
right,
therapies, self-care, but also dealing with the cognitive aspect of things, like controlling. And the cognitive aspect around these things also means, like, sometimes it's about acceptance, and when somebody can accept what's going on, that can potentially make them feel better. But, I mean, when you have something hereditary like that, there's not going to be really any one thing that could be done that makes it go away, for example. But there's probably a lot of things, a combination of things that can definitely help you and your family, the people that you care about that have it, manage it.
Right.
Yeah.
Right.
And so that's usually the best approach with those types of hereditary issues.
Uh-huh.
Yeah.
George Bush, who just recently passed away, had the similar type situation where he wound up for the last 8 years in a wheelchair.
Right, yeah.
And I'm almost to that point now.
Right, yeah. Yeah, I mean, it's you're right. There's not a lot. It's a motor sensory type of neuropathy, so it leads to problems with the nerves, and you know, the cause is... The problem with a lot of these things is when you can't identify a cause, it's hard to identify a treatment intervention. And so there's a lot of things actually that we don't know the root cause of something, and in that, when that's the case, then really it's just about management. So unfortunately, I don't have any better answers for you than you might have already known.
Right.
Yeah.
Okay, well, thanks very much.
No problem.
Thanks. You appreciate your call. There you go. That's how you start. It takes a phone call. That's all.
And that's a good example of someone seeing me is probably not going to provide much better care. But these types of things, it's the multimodal approach. When there's overall, like, not just dealing with CMT, but in general, when there's some type of diagnosis where we don't truly understand the root cause, then that means, because we don't understand it, it's likely that the root cause is multifaceted, which means that the intervention probably should be multifaceted, and there usually should be a bunch of different things being done at the same time that sort of lead to the treatment intervention.
Should make mention as well that it's not just one place where you're at. You have places. You got places all over the place.
Yes,
right?
we got places all over the place. We have a provider network across all of Ontario. But in 2019, we'll actually be expanding our physical locations. And so, you know, in 2019, there's a lot of good things to come. A lot of people, when I refer them, like, a provider is someone that's a trusted provider. Okay. So I don't control anything about that clinic. It's just, if I'm going to make a referral, I'm going to refer it to somebody that I trust, some practitioner that I trust. But a lot of people have said, I want to go somewhere where you're in charge, because then you've designed it and you've set it up in a way that you find ideal, and I listen to your show and I like your set of ideals. And so that's what we're moving towards. So, you know, we'll probably have about a dozen locations by the end of next year.
Wow.
So it'll be good. We'll really I think, and these are not just going to be like, small, like fully functional multimodal care, all the way from the massage to the physios to the surgeons to the OHIP clinics for pain and stuff like that. So it's very interesting.
You did mention, you made a brief mention of OHIP in there.
Yes.
That's some things people don't always understand. Some of that is
of course,
covered,
yeah.
right?
So if you're going to go see a surgeon because you need surgery, that's covered by OHIP. Okay. If you're going to go see, like, for example, if you see, like, let's just take Dr. Bergava, right? Sure. And he's going to do a cortisone injection. The visit is covered by OHIP. Cortisone, you have to buy it or your insurance provider might pay for it. Okay. It's like $30 or $40. But it's very hard to ever say when someone says, the services covered by OHIP? Well, It depends on which ones.
Right.
Some people do qualify for OHIP physiotherapy, and most people don't, right? And so, but then there's extended health care and things like that. So it depends on what the intervention is. It's just whatever the rules are outlined by the government. And things like therapy are not covered by OHIP.
You can get private insurance, possibly,
of course,
or workplace stuff will cover that as well.
Of course,
right?
yeah. Or if there's like something like a car accident, and there's a claim with the insurance company. But yeah, we deal with all insurance companies for our treatment centers, and all things like different MVAs, WSIB, all those things. We deal with it all.
Again, don't hesitate to reach out as we'll shut her down for another week. Back in here next Saturday as well. 1-855-55 Dr. Lou, DRLOU, info@paincarecanada.com. Till next time, Dr. Payne Show, Global News Radio 640 Toronto.